Hi, Joy.
Hi, Sita. Great. We are on time.
Yes.
Right. Okay. Tell us when to start.
Sir, you can start.
Okay. Uh, so it's such a great pleasure to do this joint activity with the Association of Physicians of India. And we have several members who are extremely active in both associations. And we thought the best thing is to leverage their position of influence in the Indian Academy of Neurology and the Association of Physicians. And this activity, hello, this activity is basically meant for physicians. And because everyone sees epilepsy, everyone sees patients with seizures. And we, of course, have an excellent faculty for today's online CME. Before that, I want to acknowledge the presence of Dr. Girish Mathur, who is the president of the Association of Physicians of India, and I would request him to say a few words. As also Dr. Mugandan, who has been very active and has been working very hard, along with Dr. Rajendra Bansal and from Ludhiana and Dr. P.K. Maheshwari from Agra. All three of them are very active members of the Indian Academy of Neurology as well as the Association of Physicians. And also, I would profoundly like to acknowledge the contribution to the development of this, the scientific program of today's meeting, especially Dr. Chaturbhuj Rathore and Dr. Sangeeta Rawat. They are the chairperson and convener respectively of the epilepsy subsection of the Indian Academy of Neurology. So with these few acknowledgements, of course, the wonderful speakers would be introduced by the chairpersons of the meeting today and the conveners of the meeting today. But first of all, it's my great pleasure to invite Dr. Girish Mathur to please say a few words. That will mark the beginning of this online activity. And then hand over to Dr. Mugandan, Dr. Bansal, Dr. Maheshwari, and Dr. Rathore.
Thank you, Dr. Gagandip. Good evening, friends. It's my privilege and pleasure to join the joint epilepsy symposium by Indian Academy of Neurology and API. It's truly a welcome move by Indian Academy of Neurology and API to start the series of webinars on common subjects in the field of neurology, especially aimed for physicians. Previously, we organized a symposium on a stroke, and today we are going to have a symposium on epilepsy. My regards to President IN, Dr. Gagandip Singh, Secretary, Dr. Meenakshi Sundaram, Dean ICV, Dr. Jyotirmay Paul, Secretary API, Dr. Agam Vora, and the coordinators, Dr. P.K. Maheshwari, Dr. Rajendra Bansal, Dr. Mugandan, and esteemed faculty of this evening, Dr. Chaturbhuj Rathore, Dr. Atmaram Bansal, Dr. Joy Desai, Dr. Sita Jayalakshmi, Dr. Sangeeta, Chairperson Dr. Puneet Saxena. Friends, epilepsy, as we all know, is a common neurological problem encountered by practicing physicians in their day-to-day practice, and is very essential and significant for all physicians to be updated about every aspect of epilepsy management, like diagnosis, drug treatment, side effects of drug, refractory epilepsy, complex disorders, and others. And it's also very essential for physicians to realize when to refer the patient to a neurophysician. I'm sure today's discussion will be very enlightening and will be wise about the treatment of epilepsy after this session. I thanks again to Dr. Gagandeep and the organizers for inviting me to this session. I wish my best wishes to the success of this session. Thank you so much.
Thank you so much, Dr. Mathur, and thank you so much for your kind words. Thank you for your encouragement. With this, can I pass on the floor to Dr. Mukundan to introduce the theme, to introduce the speakers and the topics. Dr. Mukundan, please.
Yes, sir. Good evening, sir. Respected Gagandeep sir, AN President, and Dr. Girish Mathur, sir, API President, for giving this opportunity to be in part of it. AN API joint symposium. Without wasting time, I will say a few words. The epilepsy is a chronic disorder with a lot of peculiarities. It's not a joke to live with the fear of getting an attack of seizure at any time. So one might and also get perturbated by thought of adverse effects of anti-epileptic drugs taken indefinitely. So it is one of those disorders where the quality of life may get severely compromised. So it could be interfere with the driving, employment, and marriage possibilities. So psychiatric comorbidities are common, including disorders of mood and affect. And social stigma and ill-conceived belief about the disease make the treatment extremely difficult. So learning any disease is incomplete without proper understanding of the history, and the epilepsy is no exception. So with this introduction,
I think sir's audio gets muted intermittently.
so may I request the first speaker, Dr. Chaturved Rathur, to talk on diagnosing and undiagnosing epilepsy, in which we will talk on epilepsy definition, videos of different seizures, types, role of EEG, MRI, and differential diagnosis of epilepsy. Dr. Rathur is the Senior Consultant, Department of Neurology, Zydus Hospital, Vadodara. And he did his epilepsy fellowship in Sri Chitra Tirunal Institute, Trivandrum in 2006, and ION Queen's Care in 2011. He is a trained epileptologist, more than 16 years of experience at Sri Chitra Trivandrum, and also SBKS, MIRC Vadodara. He's got a very good publication of 112 with a high citation rate and in high index journals. Work drug withdrawal following epilepsy surgery, SPECT and PET in epilepsy, NCC and drug rest in epilepsy, post-op EEG following epilepsy surgery. He also co-edited EEG in clinical practice book, which is very useful for us. With this, I request Dr. Rathur to proceed his talk on diagnosing and undiagnosing epilepsy.
Thank you, sir, for your kind words, and thank you, Professor Gagandeep Singh, as well as Dr. Girish Mathur, presidents of the IN and API respectively, and hold the team, coordinating team for this opportunity. So before starting or managing any condition, we need to know what is a particular condition, in this case, what is epilepsy, and how we diagnose the epilepsy, and in certain cases, when we come across how to undiagnose epilepsy, those who are falsely positively diagnosed epilepsy. So I will be basically dealing with introduction to epilepsy and how we diagnose epilepsy by showing the different types of the seizures and epilepsy syndromes. So let us understand the difference between what is a seizure and what is epilepsy. So both are not synonymous. Seizure is a symptom, just like fever is a symptom, while epilepsy is a disease. So a seizure basically results from the transient dysfunction in the part of the brain, and the symptoms which results from this transient dysfunction because of the hyperactivity of a group of neurons produces different types of the symptoms, which is known as the seizures. So a person can have seizures without definitely having epilepsy. So that suppose in a case of patient having hypoglycemia, patient with hyponatremia, or patient with acute neurological insult like meningitis can have seizures, but they do not necessarily have epilepsy. So epilepsy is basically a disease where there is a chronic and enduring predisposition to have seizures. So where there are unprovoked seizures without any systemic or neurological insult, then it becomes epilepsy. So basically, it is a periodic and unprovoked recurrence of the seizures. So when we call a recurrence, so once the patient has more than one seizure and which is not provoked by any insult, then it becomes epilepsy. And based upon this, till now, epilepsy was defined as 2 or more seizures. So it becomes recurrent and it becomes unprovoked. 2 or more seizures which are not provoked by the either systemic or acute neurological insults. So 2 words are important. These are the recurrent seizures and these are unprovoked seizures. So that basically defines epilepsy. So if a patient has a provoked seizure like due to hyponatremia and hypoglycemia, that doesn't classify as the patient having epilepsy. So epilepsy is a group of disorders. There are different types of epilepsy. There are variable etiology and variable prognosis. And it is important to not only to diagnose epilepsy, but try to ascertain what is the type of the epilepsy and what is the underlying etiology. So till now, epilepsy was defined as 2 or more unprovoked seizures. So once the patient has more than one seizure, then it was being classified or being designated as that a person is having epilepsy. But then the subsequent studies have shown that even after the one seizure, sometimes we can diagnose epilepsy if the chances of a second seizure is sufficiently high to warrant a anti-epileptic drug treatment. And that has been some change in the recent definition of the epilepsy. So the current, original concept, more than or equal to 2 unprovoked seizures more than 24 hours apart, so it becomes epilepsy. But if there is only one unprovoked seizure, and by certain means we estimate that the chances of a second seizure is as high as more than 60% in the next 10 years, then we can diagnose epilepsy even with one seizure. Or sometimes you diagnose epilepsy syndrome, like a patient having a epilepsy one seizure, but the patient you diagnose that have a juvenile myoclonic epilepsy, then you can diagnose the epilepsy. So it is very important, and the diagnosis of epilepsy should not be taken lightly. Once you diagnose epilepsy, it has a very profound medical, social, as well as the economical consequences. Once we diagnose epilepsy, we subject the patient to the long-term anti-epileptic drug therapy with all its medical and social implications. So we have to be very careful before stamping that person has epilepsy. So the two coming to the statement 2, when we can diagnose that person has a epilepsy even with one seizure. And to simplify is that what is the chances of a recurrence of a second seizure? So that basically to determine when we can treat the patients. So that is basically, it has been shown by the different studies. And to simplify that, we have 2 investigations. One is the EEG and one is the MRI. So EEG shows the functional abnormality. MRI will show a structural anomaly. So if patient has a one seizure, but normal EEG, no etiology, that means MRI is normal and patient is neurologically normal, chances of a second seizure is approximately 25%. But if the patient has one seizure, but the EEG is abnormal, as well as a symptomatic etiology, either in form of a MRI lesion or a neurological deficit, then chances of a seizure recurrence is more than 60%. So in this condition, once based upon the different investigation, as well as even with the single seizure, we can diagnose that person has epilepsy. If the one of them is abnormal, either EEG is abnormal or MRI is abnormal or patient has neurological deficit, sometimes the risk falls in between 40 to 60%. And then we have to really exercise our caution or maybe a clinical sense whether to diagnose this person as epilepsy or not. So simple terms, to simplify, if the patient has or the person has more than two or more than 2 seizures, or if there is a one seizure and both EEG or MRI is abnormal or neurological examination is abnormal, we can diagnose that person has epilepsy. So this has been the recent change in what our understanding and what is our classification and diagnosis of the epilepsy. So basically, once we diagnose that or once we confirm that patient has epilepsy, the next question is what is the kind of seizure and what is the kind of epilepsy person has. And this has a very important implication for the especially for planning the treatment, because as we will know in the subsequent talk that the treatment largely determine whether it is a focal epilepsy or generalized epilepsy. So if patient has a seizures which originate from the one part of the brain, like in this case, right temporal lobe, they may remain confined to the one part of the brain and may produce the manifestation. So that becomes a focal seizures. Sometimes the seizure may spread to the other side or other hemisphere and may become a bilateral tonic-clonic seizures, or the previous terminology of secondary generalized seizure. So that is the concept of focal epilepsy, where the seizure originating from the one part of the brain. On the other hand, in the case of generalized epilepsy, there is a simultaneous and synchronous involvement of the both the hemispheres or both the parts of the brain. Seizures also can originate still, they may arise from the, or they will originate from the one area of the brain, but that area is not consistent, and then is a whole of the network in the both the hemisphere which is active and which is hyperactive, or which produces a hyperactivity. So that is a concept of generalized epilepsy, basically where there is a simultaneous involvement of the both the sides of the hemisphere. So this is the basic differentiation we have to make at each point, whether it is a focal seizure or a generalized seizure, or focal epilepsy or a generalized epilepsy. And based upon this is the classification of the seizure, which is again broadly classified as seizure having a focal onset, seizure having a generalized onset, or sometimes unknown onset. Sometimes the patient has only a nighttime generalized tonic-clonic seizure. Patient comes with a nocturnal generalized tonic-clonic seizure where there is no clue, EEG is normal, MRI is normal, but the patient is having more than 2 seizures. So sometimes we don't know whether it is a focal onset or generalized onset. But broadly, largely 90% of the patients, we will be able to classify whether a patient has a focal or generalized onset. And focal onset, again, depending upon the patient's awareness is preserved or not. So previously it was called as simple partial seizures. Now that terminology has been replaced as focal aware seizure, and the complex partial seizure when there is a impaired awareness. And this can have a motor manifestation as well as some non-motor manifestation. So we'll see to that. And then there is a generalized seizures, as I told you, involving from the both the sides of the hemispheres or both hemispheres. So to give you example, what we mean by a focal seizure and what we mean by a generalized seizure, as well as what is the focal aware or simple partial seizure and what is a complex partial seizure. So if you observe this patient carefully, observe the right lower limb as well as the right side of the body. So this patient has, you can see there are the clonic jerks of the, especially the right lower limb, sometimes spreading to the trunk as well as the upper limb. And patient is responsive during this point of time. So this is a type of focal seizure where the patient's responsiveness is preserved and patient have only the motor movement, in this case, the clonic movement. So it is a focal seizure with motor onset. There is a clonic jerks of the one side of the body. So obviously the seizure is coming from the, it is on involving the right side. So seizure is coming from the left hemisphere or left motor area. So that is the one type of seizures. Sometimes patient can present with only with the clonic jerks involving the one half of the body, or sometimes progressing to involve both the halves of the body. Sometimes patient may have non-motor symptoms like the sensory symptoms, or sometimes autonomic symptoms like palpitation. And there may be the only manifestation in the case of seizures. So this girl has a severe painful sensation involving the left half of the body. So she starts with some painful sensation and she's in distress. She's aware, she is telling to her father that she has painful sensation So this is only patient is fully aware, and then there are sensory symptoms involving the left half of the body. So this is the focal sensory seizures. So the focal seizure may have a motor onset, they might have a sensory onset, or sometimes only autonomic onset. And sometimes these are the seizures which may be commonly misdiagnosed, especially sensory seizures, sometimes may be misdiagnosed as a transient ischemic attack, or motor seizure may be diagnosed as some other motor disorder or movement disorders. The important features of the epilepsy, these are the transient symptoms that usually occurs less than 1 or 2 minutes. And these are stereotyped events, same events occurring again and again, and recurrent seizures. Suppose you confuse with TIA. TIA will not be occurring multiple times in a same patient. So usually TIAs are infrequent, but these sensory symptoms or this kind, they are brief symptoms, stereotypes events, and recurrent symptoms. So that is what decide that these are the epileptic in nature. So to highlight that some patient can present with only purely simple partial with truly preserved awareness, only motor or sensory symptoms. On the other hand, when there is a consciousness is impaired, then it becomes non-aware seizures, or what we used to call as complex partial seizures. And then again, manifestation of these seizures depend largely upon where these seizures are coming from the which area of the brain. So the seizures coming from the temporal lobe have a different manifestation as compared to seizures which are coming from the frontal lobe. So let us give you an example of a temporal lobe seizure and a complex partial seizure. Please observe carefully face as well as the upper limb. So now patient becomes restless. If you observe the lips carefully, his lip smacking is there. This is a recurrent stereotype movements known as the automatism of the right upper limb. Now, if you see patient has behavioral arrest, there is almost no motor activity. Patient is not responsive at that point of time. Now you observe this left upper limb, and next there is a clonic head deviation to the left side. This clonic jerks to the left side. Left upper limb is postured. There is a vocalization. This is known as asymmetrical tonic limb posturing or figure of 4 sign, where the one limb is extended, upper limb is flexed. And then it becomes a generalized tonic-clonic seizures or a secondary generalized seizures. So these are the important manifestation, what we call as automatism, lip smacking and limb automatism. Initially, there is a hypomotor phase where the patient is unresponsive, no motor movement, very slow progression to a secondary generalized seizure with complex motor movement in the earlier part, I mean automatism and not the primary motor movement, subsequently becoming a secondary generalized seizure. So this is a classical of temporal lobe seizure or temporal lobe epilepsy. And we remember that the patients, when they come to the clinic, they will be highlighting only the generalized tonic-clonic seizure or salient features. So it is the duty of the clinician to ask whether before the generalized motor movement, is there any period of arrest or automatism which precedes the seizures. That will help us to decide whether it's a focal seizure going to a secondary generalized seizure or it is a primary generalized seizure. So always, and usually I show the patient once the patient comes to clinic, because relatives, attendants will be preoccupied with these motor movements or the tonic-clonic seizures. They will tell that patient ko jerking hota hai aur gir jata. So that we have to initially, what are the manifestations we have to ask. So I always ask that before the generalization, whether patient goes arrested, I usually show them whether this patient had this kind of movement or automatism, and then they will tell, oh, yes, he had this movement before going to generalized seizure. So this helps us to decide whether it's a focal seizure or it's a generalized seizure. And this is a classical temporal lobe seizure. And based upon this certain feature, we can decide whether it is coming from the right side or left side. So give you another example of temporal lobe, because these are the seizures which are commonly mistaken. So this lady, if you watch her face, there is a prominent stare of the eyes. Now there's very prominent lip smacking. If you watch, there is a stereotype repetitive movements of the left upper limb. So that is automatism. There is a posturing of the or immobility of the right upper limb, which suggests that seizure is coming from the left side. Again, very hypomotor seizure, complex motor movement, slow progression, and there is no generalization in this. So these are the features very typical of a temporal lobe seizure. And always ask this feature that the patient has whether, so sometimes patient come with only generalized tonic-clonic seizure. They will not give the history about the minor seizures. So always ask whether the patient has this kind of minor seizures which last for 1 or 2 minutes. So that helps us to decide is it a focal or generalized epilepsy. And now the patient is confused. You can see there the picking movements and this is clearly a temporal lobe seizures. In comparison, when there is seizures arising from the frontal or other area, extratemporal lobe seizure, you contrast it with this. So sometimes seizures may arise from the outside the temporal lobe and patient have a hypermotor behavior. Here, there is a loud vocalization. You watch the lower limb. There is a clonic jerking of the and very rapid secondary generalized seizure. So you can contrast it with the previous seizure. Here there was a very motor movements, very loud vocalization. Patient was hyperkinetic movement, and then it became rapidly generalized as compared to the other seizure where there is a slow progression. So here again, it helps us to decide that it is coming from the outside the temporal lobe. But the important thing is that we have to really differentiate whether it's a focal or a second or a primary generalized seizure. Sometimes the frontal lobe seizure especially may be very brief. We have a very hyperkinetic behavior and they may be mistaken for pseudo seizures. So this is a girl with very brief events and very loud vocalization. So she has recovered completely. Very brief event for 10 or 15 seconds, very hypermotor, emotional, fearful appearance or fearful expression and followed by immediate recovery. So these seizures, if you are not aware, it will not be diagnosed as seizure because it is not a true, like a true motor tonic-clonic movements. But these again, these events are very brief and these events are stereotyped, same semiology again and again, which helps to suggest that these are the true seizures. Sometimes seizure coming from the occipital lobe, so they might have a visual manifestation. So always ask for these symptoms or aura preceding the seizure. So this patient with a occipital lobe epilepsy, he had initially visual aura, so he is not able to see at that point of time. And then he sees some lights in the one hemisphere, and followed by there is a clonic jerks to the other side of the body, to the left side. So this initially aura is very important to ask whether to. So majority of the focal seizures will have some type of aura, especially in temporal lobe epilepsy. Ask for fear, typically epigastric aura, sometimes sensory aura if there is a paresthesia on one half of the body, suggesting parietal lobe onset, or visual auras like in colors or faces which they see before the seizure. So always ask about the aura or whether what is the feeling before the seizure, which help us to decide that there is a focal onset before becoming a secondary generalized onset. So these are the different types of focal seizures, simple partial, complex partial, arising from the different areas of the brain. Now, as compared to, there is a generalized seizure, which are generalized from the onset with involvement of both the hemispheres and typically occurs in the genetic generalized epilepsy like juvenile myoclonic epilepsy. So this seizure we have seen, it is a seizure which have an initial motor movements and followed by a generalized seizure, which was so it is a secondary generalized seizure. You compare and contrast with this seizure, which if you watch it carefully, watch the hands carefully. Now you can see there are some, these are some jerks, okay? So these are when bilateral, these are myoclonic jerks. And followed by there are no other features. Immediately patient becomes a goes into a secondary generalization, in a generalized seizure, not the secondary generalized seizure, bilateral tonic-clonic movement, and a generalized seizures. So this is another features which always ask about the myoclonic seizures, isolated myoclonic seizure, especially in the early morning hours, or the myoclonic jerks preceding a generalized seizures. So that will clinch a diagnosis of juvenile myoclonic epilepsy. And juvenile myoclonic epilepsy, let me tell you, it is almost frequently misdiagnosed epilepsy syndrome. It is diagnosed as a focal epilepsy, and patients are given drugs which usually doesn't work in this kind of thing. So always ask about, this is the one clinical part, always ask about the myoclonic jerks once a patient comes to for a complaint of a seizure disorder. Sometimes this, especially in children, they can have this kind of absent seizures. So the child become arrested, is hyperventilating, and become arrested for a period of hardly 10 seconds. Child is not responding, and then immediately recovers. So this is a typical of childhood absence epilepsy. So ask for, these are the multiple events in a per day, sometimes missed by the parents. They recognize only when the academic performance comes down, multiple events. These are the typical absence seizures, which usually occurs in the children, young children between 6 to 10 years of age as the childhood absence epilepsy. Then there are some other types of seizure with a brief generalized seizure, either tonic or atonic seizures, which occurs in children with epileptic encephalopathy or very severe form of epilepsies. Very brief tonic seizures like this. The child, so sudden tonic seizures lasting for hardly for a period of 10 or 15 seconds, and sometimes atonic seizures with head drops. So child is sitting and suddenly falls to the ground with the atonia of the body and head. So these are the tonic, brief generalized seizure, tonic and atonic seizures, which occur in children who have a significant mental retardation, have a severe forms of epilepsy, either Lennox-Gastaut syndrome or West syndrome. So in this, these are the different types of seizure we should be able to recognize. So once we diagnose that patient has a what type of seizure, we can subsequently classify epilepsy, whether it's a focal or generalized. Sometimes some patient like West syndrome may have both focal and generalized seizures, so it becomes a combined epilepsy type. Sometimes you may not be able to classify. Then you take account the etiology. What is the etiology? Well, a structural problem, genetic, infectious, metabolic. And finally, we determine what is the epilepsy syndrome, like a juvenile myoclonic epilepsy or hippocampal sclerosis. So this is the basic concept or hierarchy of epilepsy diagnosis: seizure type, and epilepsy syndrome. So once a patient comes with a presumed epilepsy, either the loss of consciousness or motor movement, there are the 5 questions you should ask this patient. Is that epilepsy? Don't presume that any patient coming with suspected epilepsy has epilepsy. So first you determine whether really it is epilepsy. Once it is epilepsy, then decide what is the type, what is the etiology, and what is the likely epilepsy syndrome. And then we can decide about the treatment. To give you an example, this is a 17-year-old boy who are having events for the last 2 years. There's a clonic movement of the left half of the body, which occurs 2 to 3 times in a day. And he has been given 3 anti-epileptic drugs for the last 2 years. And this was the event which was recorded during the video EEG monitoring. If you watch carefully, these are the clonic jerks. You can see that these are not the true clonic jerks. Patient's eyes are closed. His head is turned to this side, not to this side. And there are the different types of clonic jerks. So this was a non-epileptic event or a pseudo seizure, which was diagnosed as epilepsy for 2 years, patient given anti-epileptic drugs. So unless we suspect that patient has may not have epilepsy, this will be unnecessarily treated. So pseudo seizures or non-epileptic events, both in the children and in the adults, is the most common mistaken diagnosis for the epilepsy. They can have a variable manifestation. This patient with pseudo seizure have this kind of manifestation. They can have very flinging motor movements. See, the eyes are closed. So that is a one indicator of that. It may be a focal seizure, and this is a very frenetic motor movements. It is not a true generalized tonic-clonic seizure. and then patient stops. So this is also a pseudo seizure, where from the certain features based upon the video EEG we can diagnose, but sometimes based upon the history alone, it will be difficult to really diagnose, because it will be definitely diagnosed as a generalized tonic-clonic seizures. So always keep in mind that any person who is having a suspected epilepsy may not have epilepsy. Sometimes we thought that frothing from the mouth or tongue bite may not occur in pseudo seizures, but this is again a case of pseudo seizure or non-epileptic event. And if you look at carefully, okay, so these are the different types of movements. She sees that, and then, so there are some kind of hyper, and then she brings the saliva out. There is a frothing from the mouth, and which may be mistaken as a generalized tonic-clonic seizures. So these are the most common differential diagnoses. Commonest is in the children and adults are either the pseudo seizure or the syncopal events. These are the two important diagnoses which are mistaken as epilepsy, followed by the multiple other diagnoses, TIA or headache disorders, or especially in children, parasomnia, sleep disorders. But the two important things we should always consider is pseudo seizures as well as the syncopal events. And these are the characteristics of epilepsy we should remember. Epilepsy or seizures are brief events. 99% of that lasts for less than 2 minutes. So if any event which lasts for more than 5 minutes, suspect that it may not be epilepsy. Events are stereotyped, same semiology. So events are different, then it may not be epilepsy. Events unpredictable. Epilepsy can occur any time of the day or night without any precipitating factor, except probably in reflex epilepsy. If there is a predictability, suspect that it may be non-epileptic event. And there are blend symptoms. If there are the multiple exotics, different types of the symptoms, subjective symptom, multiple symptom, it may be suspecting that it may be a non-epileptic event. And usually epilepsy have a chronic slow onset. If the patient has a multiple events at the onset from the beginning, within the 1 month, if patient is coming to consultation, it is unlikely to have epilepsy. So these are the certain features which help us to diagnose that. But it is the high degree of suspicion. Don't assume that any patient with suspected epilepsy had epilepsy. Pseudo seizures, the two important features which I would highlight. One is the duration. If their eyes are closed during the period of unresponsiveness, these are likely to be pseudo seizures. Then obviously bizarre semiology, variable semiology, side-to-side head movements, this all indicates that patient had a pseudo seizure. If there is a post-ictal confusion, if the patient doesn't get up immediately, and if there is a stridor during the post-ictal phase, it indicates that these are true seizures and not pseudo seizures. Another condition which is mistaken as epilepsy is this kind of syncopal events, which are very commonly mistaken in adults as epilepsy. So this patient was monitored, and if you can see, is sitting and suddenly directly slumps down. There are no motor features, eyes are closed, and he falls down. And so this was a cardiogenic syncope, which was captured on the video EEG. So syncope is another differential diagnosis which is commonly mistaken for the epilepsy. And sometimes syncope can have these misleading features. Eyes may be open and uprolled during the syncope. There may be injury, incontinence, tonic posturing. But the important features are these are infrequent events and usually in a precipitating setting. The rule of thumb is that any person who is falling to the ground without any motor tonic-clonic movement is likely to have either syncope or a pseudo seizure. It is not epilepsy. The patient of epilepsy falls to the ground, it has to be a generalized tonic-clonic seizures. So diagnosis of epilepsy could be challenging, but the careful history is the most important. So the tools for diagnosis is, first tool is history, second tool is history, and third tool is history. So the history is the most important tool for the diagnosis of epilepsy, supplemented by EEG and imaging or MRI. So history is the Sachin Tendulkar of epilepsy diagnosis. Epilepsy is a clinical diagnosis. Sachin Tendulkar was the best batsman in the world. History is the most important tool in the diagnosis of epilepsy. I will be finishing in 1 minute, sir. Then once you diagnose or based upon the clinical history, depending upon what is the type of the epilepsy and what is the epilepsy syndrome, EEG plays an important role, and especially, but EEG has an important limitation which we have to keep in mind. In 50% of the patient with definite epilepsy, EEG will be normal, and sometimes in majority, many patients, EEG is overinterpreted. So that thing we have to keep in mind once we interpret the EEG. MRI is almost routine in all the patients who have a diagnosis epilepsy, and in around 15 to 20% of the patient with new diagnosed epilepsy, we can have structural lesion in the various form of this. So it may be either MTS, gliosis, or focal cortical dysplasia, calcification. So MRI is a must, except in some setting like patient have a truly generalized seizure, you are diagnosed that JME, or patient has a benign focal epilepsy of childhood, we can avoid MRI. Otherwise, MRI is a must investigation on any cases of epilepsy. In sometimes we are not able to diagnose epilepsy based upon the history, EEG and MRI, or sometimes we have to differentiate between epilepsy and non-epileptic events. So then the video EEG is the gold standard for that. So for characterization of the nature of events, whether it's epilepsy or non-epileptic, type of epilepsy, or especially for the pre-surgical evaluation, when we are doing the epilepsy surgery, video EEG is the important investigation where there is a simultaneous recording of the EEG and video EEG in a room, EEG and video, which help us to decide what kind of syndrome patient has. So to summarize what I tried to show you, different types of epilepsy, different types of seizure, epilepsy, a group of disorder with the recurrent seizure, diagnosis and is essentially a clinical diagnosis. And history is the most important tool, which is supplemented by the EEG, video EEG and MRI. Always try to establish a type of epilepsy and give to the importance to the minor seizures and another non-salient features to really decide what kind of epilepsy person has. So I thank you for your kind attention. I think what I tried to do is how to diagnose, how to classify epilepsy, and how to undiagnose also epilepsy in certain cases. Thank you.
Thank you. Thank you, Dr. Rathore, for giving an excellent talk on how to diagnose and undiagnose epilepsy. And I think you made classification look very easy with the addition of some videos. We can have questions and answers at the end of the session. Now it is my honor to welcome Dr. Puneet Saxena, who is the co-chairperson of this session. Dr. Puneet Saxena is Senior Professor of Medicine and Unit Head at SMS Medical College and Hospital, Jaipur. He is the Vice Chairman of RSSDI Rajasthan chapter. He is one of the most active members in API. He is Secretary, Jaipur API. He is Vice Chairman of Rajasthan API, and he was the Organizing Secretary of Epicon 2022, which was done successfully at Jaipur. Welcome you, sir, and I hand over to you for further deliberations.
Good evening, everybody, and thank you, Dr. Chaturbhuj, for so nicely telling us how to diagnose and classify seizures. And once we are through that, now we head on to the second part of our symposium today, that is how to manage the seizures and epilepsy. So it's regarding drugs, when to start, what to start, and how to start, and which one to start, whether you start with monotherapy or whether how you to escalate the therapy to a combination therapy. And to deliver the talk, we have Dr. Atmaram Bansal with us, who is a neurologist.
Sorry to interrupt. There is a small change. Actually, Param has requested that he should be speaking first. Is that right, Param?
No, I'll be speaking. Thanks. I'll be speaking after Atmaram.
After, okay. Sorry.
Okay, so Dr. Atmaram Bansal will be speaking on the topic which I have just told, and he is a neurologist from Medanta, Gurgaon, and he is Associate Director of Neurology there. He's the Council Member of Indian Epilepsy Society and Indian Epilepsy Association, and he's a webmaster for Epilepsy India. So let's hear out that what Dr. Bansal has to say regarding the management and how to go about it. Welcome, Dr. Bansal.
Very good evening, everyone, and it's really a privilege to have such kind of platform. My sincere thanks to IAN and API for this opportunity. And Dr. Rathore has very beautifully explained about seizure types and how to diagnose. So my job is to talk on management in epilepsy. though there are multiple sub-topics within this management, I'll try to cover that within 20 minutes, 25 minutes. So my outline is what is first seizure, first drug, polytherapy, special situations like women in epilepsy and elderly, and then a little bit about epilepsy surgery. So as it has been discussed that once there is a first seizure, there is a chance of recurrence. Rathod sir has clearly explained about the risk of seizure and other things. The only point which I want to tell is provoked seizure versus unprovoked seizure. And provoked seizures have less chances of recurrence, while unprovoked seizure has high chances of recurrence. So, and most of this recurrence happens within first 2 years, and out of that, almost 60–70% happen within first 6 months. And this is the chart to show that provoked versus unprovoked seizure. And you can see that unprovoked have high recurrence. So now, what is the approach to first seizure? So how should we manage? How should we kind of start evaluating the patient with first seizure? Sir has clearly mentioned that in epilepsy, the most important part is history. Because if you take the history in detail, you will have a fair idea whether it was truly a seizure or not. Second thing, if it was a seizure, whether it was a provoked seizure or not. So without knowing the history, a single seizure, you will not be able to differentiate provoked versus unprovoked seizure. So if you don't have an eyewitness there, it's you can easily try to talk to the person over phone, try to take the details from the eyewitness as much as possible. Then only it comes the investigations like EEG or MRI. So first seizure definitely mandates the whether this particular patient is at a high risk of seizure or not. If the patient is having clear-cut seizure and a high risk, then what kind of other issues are there, like social issues, psychological issues, drug treatment, which kind of drug to be given, what are the pros of treatment, what are the cons of treatment, and with the treatment, what is going to be the impact on quality of life if you treat versus if you don't treat. Especially previously, it was only in developed countries that driving was more important, but nowadays, even in India, most of the youngsters are working and they do have drive. And once you have seizure and then impact on driving, it anything that it becomes equally important. So acute symptomatic seizure is something when it happens within 1 week of major brain injury. That can be stroke, traumatic brain injuries, hypoxia, surgeries, SDH, infections. So these patients have relatively lesser risk of recurrence compared to unprovoked seizures, or if the seizures happen later on. So suppose somebody is having stroke today and seizure happen after 1 or 2 weeks. Those patients have high chance of recurrence rather than if it happens within 1 week of surgery or stroke. So this is a nice article by, again, Dr. Rathod sir on risk of seizure recurrence. So any patient who had clear-cut brain damage, low IQ, focal deficit, abnormality on MRI, as sir mentioned that if either MRI is abnormal or EEG is abnormal, the chances of recurrence become quite high. But other than that, somebody having history of febrile seizures, history of multiple types of seizures, patient presenting in status epilepticus, those patients have very high risk of seizure recurrence. So suppose you have diagnosed that this particular patient is clear-cut epilepsy, and now I want to start the management. So the stepwise approach is pharmacological management. We need to know the psychological issues. There are certain diets for pediatric populations, certain surgeries which are palliative surgery, and then definitive surgeries. So we'll cover one by one. So the first part is pharmacological treatment. So the traditional teaching is that if somebody has 2 seizures, then we start treatment. But nowadays, even the surgery definition has been changed, that if somebody is having single seizure and with a high chances of recurrence, that patient can also be diagnosed with the epilepsy and can be started medication. One of the example is like somebody is having myoclonic jerks and single GTCS. That patient can be easily suspected to have juvenile myoclonic epilepsy, and recurrence rate is very high and can be started medication even with single GTCS. A person who has single seizure, you do MRI and you see neurocystic sarcosis. You know that this particular patient has high recurrence, so why to wait and should definitely start anti-seizure medicines. So patient having focal deficit, EEG showing abnormality or brain showing abnormality, we can think of starting medication even after first seizure. Now coming to the what type of medicine you want to give, which anti-seizure medicine should be started in a given patient. The most important deciding factor is type of epilepsy syndrome, which Rathod sir told about classification, efficacy of that particular drug. In India, especially, the cost is a very, very important factor. As you know that most of the patient need to pay from pocket. Pharmacokinetic profile becomes equally important for the patient who have comorbidity, elderly patient who are on multiple medications. Then adverse effect is equally important. So if we have some ideal drug, then the ideal drug criteria is that it should be effective practically for all patients without much of side effects, can be given in pregnancy, no interaction, major interaction, single drug per day, OD dosages available in all forms. And you don't need to practically monitor the drug and should not have withdrawal seizure. And the last part, but the most important part, that drug should be cheap. But unfortunately, we don't have that an ideal drug. We do need to compromise on one or the other in most of the cases. So as you know that previously in last, if we leave these last 30-40 years, we had only hardly 1 or 2 drugs, and then these n number of drugs are coming. So that creates a confusion in the physician's mind which drug to start and which drug to give in a given patient. Especially in last 20 years, drugs like levetiracetam, oxcarbazepine, lacosamide, clobazam, which are there for a long in India, then perampanel, brivaracetam recently launched. So these are some of the newer drugs which are now available. So first and most important part is a physician should know the drug which mechanism of action. Most of these drugs are sodium channel drugs. The newer drug like lacosamide is a different types of sodium channel drug. Other drugs act on GABA, and some drugs have newer actions like levetiracetam and brivaracetam. They have a unique mechanism of action. Perampanel is having a unique mechanism of action acting on AMPA receptors. So first step is type of epilepsy syndrome. If you are not able to diagnose a particular epilepsy syndrome, at least you should rule out common epilepsies like juvenile myoclonic epilepsy. In those patients, if you give sodium channel drugs like carbamazepine or phenytoin, these drugs can increase myoclonic jerks. Absence seizure again can be worsened by drugs like carbamazepine, phenytoin. And if suppose you are not able to diagnose whether it is a focal epilepsy or a generalized epilepsy, you can even think of a broad spectrum drug which act equally good in both the seizures. So when we talk about broad spectrum drugs, so age-old medicine is sodium valproate, which is effective in practically all type of seizures. Clobazam is a good add-on in any type of seizure. Lamotrigine, the problem only with lamotrigine is that when you start it, you start it very slowly because of drug reactions, Stevens-Johnson syndrome. So drug rash point of view, few drugs like phenytoin, carbamazepine, oxcarbazepine, and lamotrigine. These 4 drugs, when you start, should be started very slow. Levetiracetam is again a very good broad spectrum drug, but recently it has been seen that behavior issues are quite significant in given number of cases, but otherwise it can be used in emergency, injections are available, syrup is available, and effective in all type of seizures. Narrow spectrum drugs are mostly sodium channel drugs like phenytoin, carbamazepine, oxcarbazepine, and these drugs are mostly effective in focal epilepsies, except that ethosuximide, which is again a narrow spectrum and is effective only and only in absence seizures. So when you start treatment, start with a single drug, start in small doses. Always think of the age of the patient, gender of the patient, because in female, when you start a medicine, think of teratogenicity, contraceptive issues. Starting sodium valproate in childbearing age group may not be a very good choice and should be avoided unless you don't have any other option. And in the first meeting, when you are starting medication, always talk about compliance, because it's not uncommon that patients stop medication after 3 months, 6 months once they are seizure free. So careful titration, starting slow, go slow is very important. So which drug to be used depend not only upon the type of epilepsy syndrome, but also on the patient, because an obese patient, you will prefer to avoid a drug which can increase the body weight. A drug which can cause behavior problem, you will try to avoid in psychiatric issues. So these are some of the patient-oriented approaches. So that is important, and you should know that which drug have common side effect which should be avoided. So in terms of comorbidity, if somebody is having frequent headache along with epilepsy, so sodium valproate and topiramate are drugs which are given otherwise also for migraine. So these drugs may help. Drugs like carbamazepine, oxcarbazepine, lamotrigine, valproate are given for mood stabilization, and drugs like levetiracetam, topiramate, phenobarbital can worsen it. Clobazam can be sleep inducing and can be given if you have sleep disturbance. Sorry, just I need to take one very, very urgent call. Sorry. Yeah, sorry. And cognitive issues wise, drugs like phenobarbital in elderly can have cognitive worsening. Drug like topiramate, zonisamide sometimes have cognitive worsening. As I was discussing about weight gain, sodium valproate can worsen the weight. Topiramate and zonisamide are the drugs which help in weight loss, so can be given in obese patient. So these are some of the comorbidities and drugs which can be preferred. Newer drugs like lacosamide, perampanel, brivaracetam, eslicarbazepine are for focal epilepsy. Levetiracetam, zonisamide, and topiramate are for neuronal epilepsies. So when you suspect a person having clear-cut idiopathic generalized epilepsy, then sodium valproate, lamotrigine, and lamotrigine are the drug of choices. If it is add-on drug, then you can add clobazam, lamotrigine, and drugs like topiramate and even zonisamide have been used. If it is focal epilepsy like neurocystic psychosis, carbamazepine, oxcarbazepine, lamotrigine, levetiracetam can be used. Add-ons like clobazam can be easily used. Drugs like lacosamide are available in injectable form from focal epilepsy. So if somebody is in focal status, you can even use lacosamide as injectable. Coming to the woman with epilepsy, there are certain important questions about a woman and having epilepsy, about marriage, pregnancy, which drug, will the seizure issue happen in pregnancy? So coming to the important part that whether the medication will affect the baby, whether the delivery will be abnormal, whether the feeding is allowed or not. A female with epilepsy is not a contraindication for pregnancy. More than 90% of the female with epilepsy will have normal pregnancy without any issues. So don't discourage about pregnancy, because almost 1/3 of the female do not consider having epilepsy, children because of epilepsy. So what should be done? Can I stop medicine before pregnancy? You can, if the patient is seizure free for more than 2 years, but not in all cases, because some patients who have high chances of recurrence, you should not stop medication. And if you are planning to stop, wait at least 6 months before planning pregnancy. So today you stop anti-epileptic drug and wait for 6 months because the recurrence rate is high in first 6 months. If it is active epilepsy, you will have to give medication, you can't stop it. Next part is about will my seizures control worsen during epilepsy, pregnancy? Almost 50% chance it may not worsen. 96% of the pregnancy will have normal children. The risk of teratogenicity is 4 to 5%. So if somebody is having epilepsy, then confirm, discuss about the need of anti-seizure medicine. Before pregnancy planning, you can change the medication if required. You can think of the medication which have less chances of teratogenicity, give folic acid and chloroquine. Screen for malformations at 18 to 20 weeks with a quadruple test and level 2, level 3 ultrasound. Breastfeeding should be encouraged because the side effect related to breast milk secretion of anti-seizure medicine versus the benefit is much more than side effect. So plan should be that and ANC care, malformation screening, continue medication, vitamin K, type of delivery should be depend upon the pregnancy indication rather than epilepsy. And breastfeeding should be advanced. So epilepsy in elderly, just 3-4 slides. In elderly, there is always a diagnostic dilemma whether it is a true seizure or not. As you know that arrhythmias, hypoglycemia, even hyperglycemia can present with focal seizure in elderly. Somebody who is having 500, 600 sugar can present with unilateral jerks. Orthostatic hypotension, drug-induced pseudo-seizures can happen even in elderly. They are not unusual because depression is quite common in elderly. So if somebody is having a first-time seizure in elderly, always take a reliable history, eyewitness, and then always rule out reversible causes like hypoglycemia, hypothyroidism. There is a separate talk on provoked seizure and metabolic and systemic issues. Investigation-wise, other than the investigation required for epilepsy, you need to do from brain point of view, maybe Doppler, Holter, routine testing, MRI, and EEG. So the treatment point of view, the drug should be, the purpose is to control seizures, avoid as much as side effects as possible. And then discuss with the family members, because once you start medication for elderly, it may be practically lifelong. Which drug to be used? Avoid the drug which is having enzyme induction like phenytoin, oxcarbazepine especially should be avoided because the chance of hyponatremia is much more with oxcarbazepine than carbamazepine. So we can give drug which have least enzyme induction like levetiracetam, lamotrigine, lacosamide. So these are some of the drugs which can be used. And dose requirement may be almost less than 50% if it is the age is 80s or 90s. Now I'm coming to the failure of medication and complicated epilepsy. So if first drug fail, always rule out non-epileptic event. Dr. Rathod has shown very beautiful videos of pseudo seizures. Always try to get a home video. Nowadays, everybody is having mobile, and that may help in making a diagnosis. Seizures may not be improving because of the wrong drug also or the compliance. So approach is like check for the drug level if you can suspect about compliance issues, check for the diagnosis, check for which medicine, and if suppose everything is correct, then it comes in the category of drug-resistant epilepsy. So when first drug fail, you can add another drug, then tapering the other drug, or first go the high dose of the second drug and then start tapering. So these are some of the criteria to add the second drug. So substitution after going a higher dose of second drug may be a better choice rather than parallelly going one dose increasing, another dose decreasing. Sometimes you may need to continue 2 drugs. Sometimes if the second drug is working nicely, you can stop the first. Suppose the second drug is not working, then you may have to try the third drug. So when we are adding medication, it is basically a polytherapy. So there are few guidelines about using second drug or polytherapy, that we should use a second drug of a different mechanism of action. So if you are using a sodium channel, don't add another sodium channel. Adding carbamazepine with phenytoin is not a very good choice. Add a drug which have GABA action like clobazam or phenobarbital with phenytoin rather than sodium channel drugs. Or you can add broad spectrum drugs. Adding 2 GABA may not be a good choice, or 2 sodium channel definitely is not a good choice. So good combinations for absence epilepsy can be sodium valproate and ethosuximide, sodium valproate and lamotrigine for generalized epilepsy, lamotrigine, topiramate, carbamazepine with clobazam, phenytoin and phenobarbital combination is age-old combination and be used by many other, including quacks and all. So successful polytherapy is when you don't have drug-to-drug interaction, minimum side effect, and we are able to control without having too much of drug overload. So last 2 or 3 slides, drug-resistant epilepsy. So if somebody is not able, out of 100 patients, Almost 50% of the patient you can control either with one drug or with the two drugs. Almost 2/3 of the patient you can easily control. Rest of the patient need further care, and almost 15% you can cure by surgery. So what is the refractory epilepsy or drug-resistant epilepsy? If you are not able to control with more than two drugs, seizure having more than 2 per month, or even one seizure in more than 2 months for last 2 years, this was the previous criteria, but nowadays the duration doesn't matter, frequency doesn't matter. If you have tried two medicine and patients still getting seizure, those patients should be referred to a specialist where further workup can be done and even epilepsy surgery can be considered. So always ask questions. Is my diagnosis correct? I'm giving the correct medicine, correct dose, is patient taking medication or not? So these are the questions which indicate pseudo-refractiveness. Then we need to see the MRI, we need to see the triggers. So approach is, if patient is having refractory epilepsy, see the MRI. If there is a clear-cut abnormality on MRI, we do video EEG and then we operate the patient. So epilepsy surgery is a teamwork. We need to see the clinical detail, MRI, video EEG. The purpose of video EEG is we admit the patient, we monitor the patient for 2 days, 3 days, 1 week. We try to get the habitual seizures, stop the medicine, and correlate it with the MRI. If suppose MRI is showing left temporal abnormality, video is showing left temporal abnormality, then operate the patient depending upon classical type of seizure symptoms. So it's a teamwork. We need to have a full team before operating, because surgical outcome is very good if patient case selection is good. So unfortunately, we have very limited number of centers in India, and we are fortunate that at least in my center, we are able to do epilepsy therapies. Thank you.
Thank you. Thank you, Dr. Ratna, for the lucid presentation. Next, may I request Dr. Parampreet to talk on how and when to take the anti-seizure medication. Dr. Parampreet is the professor in charge of comprehensive epilepsy program, Department of Neurology, PGI Chandigarh. He is a coordinator in communication and healthcare program. He is the chairman of Indian Epilepsy Association, Punjab chapter. He did DM Neurology from PGI Chandigarh and fellowship in epileptology. His areas of interest are resistant epilepsy, epilepsy surgery, communication, and healthcare. He received many awards and achievements. He was awarded Clinical Epileptology Fellowship by the Epilepsy Society of Australia in 2005. He served as the Executive Committee in Indian Epilepsy Association and Indian Epilepsy Society. He was placed on the faculty of 1000 by the International League Against Epilepsy. With this introduction, I welcome Dr. Parampreet to speak on how and when to take the anti-seizure medication.
Thank you, sir. And thank you, IE and API, for asking me to talk at this forum, and thanks the chairpersons and conveners, see my good friends around. My topic for today, as introduced by the chairperson, is when and how to taper anti-seizure medication. I just put into the screen. Is it good voice and audio? My connection. Can someone tell me, is it my voice and video is fine?
Yes, sir, your voice is at times breaking, but
It is breaking.
whether I am able to, in my system,
Sir, your internet connection is weak.
Okay. Okay. Yeah, I'm on a mobile connection, but can you hear me clearly or not?
Yes, you are audible, sir.
Please proceed, sir.
Okay. Well, please let me know. I'll if the voice is not. Otherwise, it won't be any useful. And again, I go to the first slide. As all the neurologists and physicians, we know that we treat a lot of cases of epilepsy, And when you tell the patient they have epilepsy and they have to be on long-term treatment, one of the first question which they ask, all of us have experienced, is that for how long? So I'll maybe put my video off. That may help. Anyway, so for how long? Because we have difficulty in taking 5-6 days of antibiotics, and asking someone to take lifelong treatment is not easy. So that is why the question of discussing taking off drugs is important. Also, epilepsy is a unique illness in the sense that you have to take years of medicine for maybe just a few myoclonic jerks and a positive EEG. And the medicines are purely symptomatic. There are other issues like social issues, pregnancy concerns, as Dr. Atmaram just said, cognitive issues, side effects. And to add to that, as shown in the definition, there is a new part to the epilepsy definition called epilepsy resolved, in which if you have been off seizure, without seizure, off medication for 5 years, you can go into that category. And for that is why also it may be important for patient to stop the medication to get into the epilepsy resolved category. But why is this topic still controversial, as many of the issues in epilepsy? It's because there is no uniform, there can't be uniform recommendations for all patients. There are different types of epilepsies, and every epilepsy and seizures have different length of medication to be taken, some from few weeks to almost lifelong. So it's difficult to have one shoe which fits all. Then there are no gold standards. It's very unpredictable. If the patient, when will the patient have a seizure after stopping? If you have a seizure, if the patient asks us, the seizure can happen 10 days after stopping medication or 10 years after stopping. Although it may be more common in the early time, but it can happen anytime. So that is why it makes all the more difficult to be very clear on this. Then there can be specific needs of patients depending upon their lifestyle and time in life. Somebody's getting married, somebody's pregnant. We have ladies coming up to us and saying that even when they are on safe medications, that oh, I'll delay my marriage for a couple of years and I want to be off medications. The other things like driving and again unpredictable consequences of seizures. So that makes it all the more difficult. But I mean, we have to form some guidelines. And one of the biggest studies, although there is other literature published on this, is what we call as a MRC trial published in Lancet long back. It was a big trial, more than 1,000 patients, which they compared people who continued anti-seizure medication versus slow withdrawal. All these patients were at least more than 2 years of seizure freedom. The thing is that they did include people with myoclonus absence, maybe juvenile myoclonic epilepsy, which the recurrence rate is high. Anyway, the overall rate of seizure freedom was around 80% for people who continue treatment beyond the 2 to 3 years, and about 60% who withdrew from treatment, which is a big majority. Around 2/3 of people did not have seizures. So it's a good thing to consider anti-seizure medication tapering. But what does guide us? I mean, something has to give us a guidance at which are the patients who are going to be safe and which of the patient may not be safe, although it's never 100%. So there are some collection of from many publications. These are, if you have a symptomatic epilepsy, you are more prone to have recurrence than idiopathic generalized epilepsy. If there's a family history of seizure, if the age of onset of seizure was before 2 or after 10 years, basically not in childhood, that increases the risk of recurrence. Then if there's a previous history, patient had recurrence on tapering, low intellectual IQ, high seizure load, and if there was difficulty in control in the first time, if you had to use multiple medications, patient has a neurological deficit on examination, abnormal EEG, before or during tapering, all these features make it more likely that this patient may have a recurrence. So that needs to be discussed, even if they fit into the standard 2 to 3 years course limit. And then there are epilepsy syndromes like already discussed, juvenile myoclonic epilepsy and developmental epileptic encephalopathies where the chance of recurrence is extremely high. There are also people who have tried to make automated tools. You can take a screenshot of this site where, I mean, it's not 100% precise, but it can, they have tried to give us an idea by filling in things that whether patient will relapse or not. There's also this review by Dr. Rathore, who just spoke before Dr. Atma Ram and Ross Peterson, which talks about seizure tapering in epilepsy in remission. So now that if we have some idea that who are the people who we can taper, we come to that when to taper. So this is another question. This is probably one of the most important questions. So the data shows that if we people at less than 2 years, there is a higher chance of recurrence. The chance is not very different between 2 to 4 years. And by 5 years, it has moderately decreased, but then it is not that much to base your decision on. So what we normally do is that in people who are safe to come off medication or who want to come off medication, we consider 2 to 3 years. 2 years if somebody is in a hurry, as I said, getting married, and 3 years in routine patients. That is how I do, because since we don't have 100% clarity, we all have made our own adjustments to it. Then how long, over what period of time the drug should be withdrawn? There was this Cochrane review by our friend Lakshmi Narasimhan and Sridharan Ramaratnam from Chennai, and continued and finalized by Fernando Loro, where they compared people who were tapered off in 1 month versus 6 months. Although the 6 months tapering did have a lesser chance of recurrence, it was not statistically significant in this review. And they interpreted there is not enough data available actually to be very sure that how many months we should take to take off drugs completely. But there is other literature, as I quote. So between 6 weeks to 9 months has been thought to be almost equitable risk. This is probably, if I believe, maybe for monotherapy. I'm not sure about that. But the reason for that is that if we have more than one medication, 2 or 3 drugs going on, then we take longer. We don't take off everything in 3 to 6 months. And type of anti-seizure medication, some medications on withdrawal like benzodiazepine and even other drugs may cause withdrawal seizures. So those we have to be a little careful about, go slow on them. And then of course, the lifestyle of the patient. What we usually do is we taper them off over 3 to 6 months time, which is many of the centers do it that way. So what is the effect of quality of life on people who are tapered? So this is very simplistic, that people who were tapered successfully have a better quality of life. But the important part was that who relapsed after withdrawal, these are studies by Anne Jacobi and others, that people who withdraw only around less than 10% regretted their decision. So that makes it that they really wanted to come off the medication. This scored comparably to the ones who never tried. So we need to remember that it is important for many patients to try withdrawal. Of course, safety has to be considered. Then there are some peculiar patients issues where it's important to understand that what is the patient's perceived benefits from continuing or withdrawing. People may have exaggerated perception of risk from stopping, that they may have uncontrolled epilepsy or injury or accident. Some of them are realistic, but they may be over thought. On the other side, people may have exaggerated perception of risk of anti-seizure medicine. As I said, there are many people, even people who are on lamotrigine, levetiracetam, who are relatively safe, don't want to undertake pregnancy. So we need to talk and rationalize the patient's fear of either continuing or stopping anti-seizure medication. I'm sorry to check. Is it going fine, the audio now?
Yes, sir, it's fine.
Great, thanks. Thank you so much. So it's difficult to assess in advance that what will be the consequence of seizure. Let's say patient has a seizure and whether they will get an injury or not. If they're coming down the stairs, the chance of injury goes up. If they are driving, the chance of injury goes up. If they are sitting quietly, it may be less. So there are a lot of uncertainties in telling exactly what the patient is going to fare when we take off the drugs. There are risks to withdrawal, as we know that in uncontrolled epilepsy, especially there is risk of SUDEP in status epilepticus or continuing seizures. There can be injury, and there are social consequences, loss of driving license in some countries. And so these need to be discussed with the patients. Seizure-related injury we need to know, because this is one of the biggest fears of patients is how much injury they are going to have. Mostly it is sometimes overestimated if they are not doing risky activities, which we all ask them not to. The risk compared with people who had seizure versus general population was 17% versus 12%. Basically 6 to 10% additional risk of injury in these people. So it's not very high, but it also depends upon the circumstance where the seizure occurred, I said. So it has to be individualized. In the whole of MRC trial, there were 2 deaths, both in the continuing group, paradoxically, possibly incidental. Another question which comes during these meetings is how much is the EEG beneficial in deciding whether we should take off? It's not completely related to the risk of recurrence. There is more association in generalized epilepsies where there are more EEG changes. They may help us. But abnormal EEG before tapering does increase the risk. And especially it has been found in some studies that if we do a EEG during tapering and it shows worsening or increased activity, that is a higher risk of recurrence. Another question is that if we stop and the seizures come back, will they get controlled? So that fear is there that it may never get controlled now that they are controlled. So literature shows that 80 to 90% of people will get controlled again on the same or slightly different anti-seizure drugs. But there is a small minuscule risk, about 10 to 20%, where a well-controlled patient may become difficult to control after withdrawing and restarting anti-seizure medication. To end, there are other things which we need to keep in mind before tapering, because many of these drugs may have more than one effect. Valproate and carbamazepine, lamotrigine may have mood stabilizing effects, which things may worsen once we take off anti-epileptics. So the thought has to be given about the comorbidities. Migraine, topiramate may be controlling migraine, and so that needs to be thought of before we take the decision to withdraw. So anti-seizure medication withdrawal is usually not a stated reason. Sorry, that is from the surgery slide, wrong slide. Ending remarks is that the supreme aim is to have a quality of life of the patient improvement. So quality of life is likely to improve post-withdrawal, but we do not want to put the patient in unreasonable risk. And that is where the first table I showed on the list of things which help us see which patient may have a higher risk. And we may ask them to take longer medication. Not all of them can stop at 2 or 3 years. And consider the high-risk factors. We need to personalize the risk during their lifestyle, their profession, and we should not make generic recommendations. The best thing is to put the unbiased facts in front of the patient and let them decide. So in things like this, where it is not 100% clear that when to stop or in which patient exactly, what is the prognosis after stopping, we need to involve the patient. To end, we need to have what we call, and I do communication skills in medicine also, as along with this epilepsy thing. So this is something where we talk about in our modules is shared decision making. Individualize and make see the patient's values, their risk, what they want to do. Of course, we may have to hold their hand to get over the line, but taking their values and what they want to do and what does this patient want is also very important. Thank you.
Hello, so we can't hear you. Hello.
Dr. Mugundan, we cannot hear you.
So thank you, sir, Dr. Parampreet, for the lucid presentation. You can start, sir.
So we move on to the next session, and we have Dr. Joy Desai with us, who is Director of Neurology at Jaslok Hospital, Mumbai. And he will be speaking on management of seizures and epilepsy in special situations, like the metabolic problems, the hepatic and the renal conditions, and the structural or maybe the infections like neurocysticercosis, which we very commonly encounter these days, the multi-system involvement where the liver and kidney, they are faltering. And we are encountering seizures and epilepsy in those subset of the patients. So I welcome Dr. Joy Desai, and the time is 25 minutes for you.
Thank you, IAN, and thank you, API, for inviting me to participate in this meeting today. Am I audible? Can you hear me?
Yes, we can.
Yes, sir, we can hear
Super.
you.
And is my screen visible now?
Yes, sir.
Yeah, please go on.
Yeah, super. So great. My brief today is to speak to you about seizures in systemic disease. And in 25 minutes, I'll try and give you a kind of bird's eye view of how one could approach the entire spectrum of seizures that one can see in systemic disease. Now, we know that seizures in systemic disease can occur either as an acute transient manifestation of an actionable CNS dysfunction during a metabolic insult to the brain. It can be focal or it can be generalized. And sometimes it may be a harbinger of persistent seizures due to a kind of enduring alteration in CNS stability, sometimes often associated with a structural change in the brain that may not be alterable. Now, in some situations, seizures may reflect a very idiosyncratic cerebral response to either a pre-existing medical situation like accelerated hypertension or to a chosen medication for a given condition. And lastly, in some situations, in restricted settings especially, seizures may develop due to recurrent CNS effects of a systemic disease or an infection. And we'll talk about some common examples around the world where one may see conditions like this. You heard Dr. Atmaram speak today about seizure mimics, and he talked about hyperglycemia. Now we know that as physicians, a lot of you will see patients who have non-ketotic hyperglycemia, and these are individuals with poorly controlled or regulated blood sugar levels, and they can present in a variety of ways. Some of them can present with hemichorea, others with focal seizures, still others with reflex seizures, and there have been case reports of patients who present with epilepsia partialis continua, and even status epilepticus can be triggered by a seemingly innocuous and a common medical derangement within the internal milieu of the body, like non-ketotic hyperglycemia. So something to think about, and knowledge of this is not something new. This from the 1990s, we are aware of it. And there are other situations when the blood-brain barrier undergoes a reversible transient permeability alteration. And these are individuals who present with headache, vomiting, some seizures, a little alteration of conscious level, and visuoperceptive dysfunction. Some of them may not be able to navigate their way in space and time, and in others, there may be cortical blindness due to involvement of the posterior parts of the brain by vasogenic edema. And if one did an MRI scan, one would see changes that look like this. And this condition is known as reversible posterior leukoencephalopathy syndrome. And as one can gauge from the nomenclature, it is a temporary alteration in blood-brain barrier permeability. The frequently associated medications that can precipitate this are drugs that we use in a immunosuppressed environment of transplants, cyclosporin, or rheumatic conditions, rheumatological conditions, methotrexate, tacrolimus, and in other situations, L-asparginase for tumors, vincristine, and sometimes even drugs like atriomycin and erythropoietin. So what one can derive from this is that in some people, the blood-brain barrier permeability is exclusively sensitive and may undergo a change given a precipitant of something like this. Then for physicians, I think it's important to understand that yes, sometimes a systemic medical condition could present for the first time with recurring seizures. And we all know that I'm talking to a whole galaxy of eminent physicians here, and acute intermittent porphyria, which we know is a metabolic anomaly of delta-aminolevulinic acid metabolism by the dehydrase, and in its conversion, it can alter to porphobilinogen to produce acute intermittent porphyria. Many of these individuals can precipitate with seizures, present with seizures, not an uncommon thing, and you can have complex partial seizures with or without secondary generalization. Some of them may even have myoclonus and can mimic a seizure disorder. And if there is a background of a previous peripheral neuropathy or a persistent peripheral neuropathy without the usual suspects as an etiology, or there is a background of psychiatric dysfunction, one should have a high index of suspicion to investigate for porphyria. So the triggers for this sometimes paradoxically are antibiotics, medications, and anti-seizure medications like the barbiturates and phenytoin and carbamazepine. And once in a while, these seizures can be precipitated, porphyria can be precipitated by excessive consumption of alcohol. And important to note that different metabolic processes can be contributors to the seizure vulnerability: hyponatremia, the drug itself, and cortical changes, pontine myelinolysis, brain ischemic change, etc. So what happens in porphyria is that once precipitated and one understands it, one can clearly has to raise a red flag that the usage of drugs like carbamazepine, phenytoin, lamotrigine, all the sodium channel medications are contraindicated. They are potentially porphyric and one has to avoid them. Perhaps the only drugs that are really safe are gabapentin, levetiracetam, and pregabalin. Now we all know that pregabalin and gabapentin are used in India commonly as pain modulants, being alpha to delta modulants, but they have shown a similar efficacy to the existing drugs, anti-seizure medications in clinical trials. So they can be used as an anti-seizure medication too, but they are limited by the sedatory effects of the medication. Now we know that acute seizures with cognitive dysfunction, psychiatric manifestations can be a harbinger of underlying mesial temporal lobe inflammatory disorders like acute herpes simplex encephalitis. I mean, we know that they can present with acute recurring seizures, and they are a common cause of status epilepticus of a complex partial kind. And the MRI is very typical, can show very graphic signal changes as shown in this figure in the temporal lobes, in the insula, and it's often unilateral. The EEG shows a generalized theta delta activity over the affected temporal regions. An important thing to understand is that in many of these patients, the seizures respond to standard medications and antiviral drugs like acyclovir. However, over a variable period of time, some of them can relapse, and when these relapses occur after a variable period of time, 3 to 6 weeks, sometimes over a month, these can be of an autoimmune origin. So sometimes the injury to the brain can unmask the NMDA receptors, and the body's immune system can develop anti-NMDA antibodies, and these can have an immunological precipitation again of behavioral change, psychiatric dysfunction, and seizures. And these seizures may not respond to anti-seizure medications, but they may respond to immunomodulants like intravenous solumedrol and other medications of a similar mechanism of action. So this kind of unmasking or a late development of autoimmune anti-NMD encephalitis has been described not just with herpes simplex, but with other viruses and organisms too, like Bartonella, Borrelia, and Japanese encephalitis, but these are relatively rare. With herpes simplex, it is not as uncommon as one would like to think. And herpes simplex by itself, therefore, is a very potentially epileptogenic insult to the brain. It can manifest as status epilepticus in the acute encephalitic phase, with inflammation in the mesial temporal lobe. It can leave behind a very ravaged and damaged network in that region, producing refractory epilepsy because of hippocampal atrophy and neocortical tissue damage. Uncommonly may resurface as an anti-NMD antibody mediated refractory epilepsy requiring immunomodulation, as discussed. And rarely, some patients and children with refractory epilepsy, and when the glial scars are surgically resected, they may reveal smoldering granulomatous HSV infection. And I'm showing you one such example. How common this is, we don't know, but this is something that can actually occur. And localized smoldering kind of immunologically balanced inflammatory process can occur in the brain, in the very regions of the brain that are commonly affected by herpes simplex. So something to remember and to think of when one sees an unusual problem. So it's great to have Dr. Gagandeep here. And you heard the person who introduced the subject today, that cysticercosis was mentioned. And we know that cysticercosis is a very common infestation of the brain in this part of the world. And now, of course, we are seeing lesser numbers, but there was a time a few years ago, about a decade and a half ago, when it was substantially common. Now, the identification of cysticercosis is not difficult. Sometimes it can pose a challenge in differentiating the granulomatous lesions from tuberculomas. But what is interesting is that Dr. Gagandeep and others with Yosemir Sander showed that in some people, over a period of time when they have seizures from, especially from calcific cysticercosis, can go on to develop a secondary mesial temporal lobe epilepsy, as shown in this MRI figure, and may then develop refractory seizures due to a secondary MTS that may need surgery. And such evolutions have been described by others, Fernando Sendes and Elaine Kobayashi from Brazil, and from other parts of the world where cysticercosis is common, Ecuador, these kind of patients have also been reported. I mentioned earlier that sometimes innocuous sounding infections, which physicians commonly treat, falciparum malaria, for example, can produce acute seizures during the falciparum malaria. We commonly see that in those parts of India where falciparum is common, but peculiarly sometimes in Africa, where therapy options are often delayed and not available in certain parts of the continent, the person who has recurrent falciparum malaria can actually develop epilepsy. And there is a very elegant study that was published in Brain, the study that I showed you, where in a significant number of people, status epilepticus occurred in falciparum malaria, about 11.8%, repetitive seizures in a good 50%, and focal seizures in a small number of about 7.5%. So what it tries to tell us is that even seemingly treatable conditions like malaria can leave behind an enduring brain injury with unstable networks. And in some of these individuals with malaria, we have found antibodies to sodium channels, and in some, seizures can actually occur due to chemoprophylaxis with agents like mefloquine, and even standard medications like chloroquine can actually give you acute seizures and psychosis. And from Jaslok Hospital, we reported a case like this in the early 1990s when we had a patient that developed this entire spectrum after chloroquine. I had the opportunity of looking after some patients from Africa who had presented with occipital seizures, and they had a peculiar looking granuloma, and on surgery and excision, they turned out to have schistosomiasis. So schistosomiasis is common in some parts of the world, in some regions in Africa, and in some regions of the Middle East, and that can constitute an unusual parasitic invasion of the brain, producing recurring seizures and regional brain injury. So what are the challenges in hepatorenal disease? Well, hepatorenal diseases are commonly associated with seizures in an acute setting. And like in other systemic diseases, one needs to understand the company that it keeps. So many patterns of clinical precipitation can occur. And there is generally the systemic ailment variability that determines the algorithm for decision making. So the management of seizures in these circumstances is compounded by AED pharmacokinetics because of end organ problems, pharmacodynamics, protein binding, and elimination patterns. So therefore, the physician and the neurologist has to be well trained in nuances of internal medicine and must know the pharmacology well, so that factoring in the end organ dysfunction can result in an optimized choice with anti-seizure medications. So in acute hepatic encephalopathy, the seizures are almost universally associated with hyperammonemia. And we know that Roger Butterworth had done a lot of work on this, showing that the astrocytes in the brain swell up and they produce brain edema in the hepatic encephalopathy process. And a type 2 Alzheimer kind of astrocytosis occurs in the brain with hyperammonemia, triggering seizures. And this is the purported mechanism that the high ammonia levels alter the function of the glutamate transporter that regulates glutamate across the synapse between neurons and astrocytes. And this can be the precipitant, and one has to treat the hyperammonemia by gut cleaning measures to make sure that the ammonia settles down. It's only when the ammonia settles that the seizures actually come under control. Once in a while, in conditions like hepatitis E, especially on the background of pregnancy, you can have a rapidly progressing encephalopathy with seizures, coagulopathy, and a secondary hepatorenal syndrome. And it's unclear whether the part of this contribution severity is from a direct viral pathology or a transient immune alteration. There is this HELP syndrome, hemolysis, elevated liver enzymes, and low platelet count. And it can be associated with preeclampsia because of hepatic endothelial disruption, DIC, and microangiopathic hemolysis. And clinically, it presents with worsening coma, ischemic cerebral insult, severe seizures, secondary renal failure, and secondary sepsis. So one must know that these end organ dysfunctions can present in a variety of ways. And we know that both in acute or chronic liver disease and in patients who have been transplanted, one needs to use an anti-seizure medication that has relatively no hepatic metabolism. And currently, levetiracetam fits the bill very well. And it's been the drug of choice in these systemic settings of hepatic dysfunction. What about renal failure? Well, in renal failure, the nuances are fairly variable, and one knows that encephalopathy and seizures can be a part and parcel of uremic encephalopathy, of Wernicke's encephalopathy due to dialysis and dialysis disequilibrium, and rarely hypertensive encephalopathy, and can also present in an RPLS-like syndrome. Some patients with renal dysfunction are vulnerable to electrolyte disturbances, and that can trigger seizures too. And once in a while, antibiotics like cefixime or ceftazidime, for example, can precipitate seizures and can be difficult to treat in a renally deranged setting. While we know that dialysis disequilibrium incidence is now much less, but it's characterized by seizures, tremors, ataxia, disorientation, and sometimes coma. And we know that in patients who undergo dialysis, the dialysate can alter the balance of osmolar products in the blood, producing a derangement in blood-brain permeability, resulting in the vulnerability to seizures. And these can be associated sometimes with the low thiamine levels too. So it always makes sense to make sure that thiamine can be given in such individuals to alter the metabolic environment rebalance it, so to speak, and make sure that seizures are easily controlled. When seizures occur in the first 4 weeks of organ transplant, then one worries about calcineurin inhibitors, neurotoxicity. One has to worry about acute rejection. We now know that rejection encephalopathy is a form of RPLS. One has to worry about Wernicke's encephalopathy after frequent IV infusions. And of course, there is a specter of opportunistic infections. And for calcineurin inhibitor CNS toxicity, there are various risk factors. I'm talking to very well-informed physicians, so I know that you know that hyponatremia, fluid overload, arterial hypertension, low cholesterol, and low magnesium, these are commonly identified risk factors in this setting that can precipitate seizures. Now, when we make choices for hepatic impairment, then levetiracetam is the drug of choice. One can also use gabapentin, pregabalin, and topiramate. For porphyria, again, levetiracetam remains the choice, and the other options are pregabalin and gabapentin. And in renal transplant patients, valproate is often the drug of first choice. And if valproate is contraindicated in some way, then lamotrigine or one of the benzos can also be utilized like clobazam. For heart disease and lung disease, there's a whole host of medications that one can use. But since there are drug-drug interactions with the numerous medications that patients may be consuming for their systemic disorder, levetiracetam remains the first choice because it has negligible drug-drug interaction with any of the other co-medications. And lastly, before I stop, since I have only 20 minutes to speak to you all, one must not forget in older seizures. You heard Dr. Atmaram talk about seizures in the elderly. When seizures start de novo, Beth Mallow's study way back in 2007 clearly showed that patients who are already in middle life who develop seizures for the first time don't have any inflammatory or autoimmune clinical features. If their MRI scans are normal, it's vital to take a good sleep history and understand whether they have obstructive sleep apnea. For obstructive sleep apnea or sleep disordered breathing can often present with a variety of seizure episodes. It can present with genuine seizures, can present with episodic events that mimic seizures, non-epileptic spells, and in some patients who have seemingly refractory epilepsy, if one understands and diagnoses underlying sleep apnea and it is appropriately treated with CPAP, then the seemingly refractory epilepsy can become better controlled. So this is something that's really treatable, something to be aware of and to remember when we are dealing with patients. I think this is my last slide. I'm going to stop here. And I thank you all for your attention. I've tried to give you a kind of quick bird's eye view in about 20 minutes that I was allotted of how I see seizures in the setting of systemic disease. Thank you very much again.
Thank you, Joy Desai, sir, for the excellent presentation on epilepsy in special situations. We have some questions at the end, sir. The next talk is on status epilepticus. It is the other major challenge faced by the emergency physicians. The outcome in status depends on the etiology and also on how fast one is able to arrest the seizures. Hence, it is a medical emergency. The speaker is none other than Madam Sita Jailashmi, ma'am. She was in NIMS when we were observers. In 2005, as a DM student, Madam was in NIMS. Now she is the consultant neurologist in KIMS, Hyderabad. Her area of interest is epilepsy and epilepsy surgery. She has more than international journals, contributed chapters to textbooks in neurosciences. She is a DNB teacher and PhD guide. She received Master Teacher Award by the SHINE team. She is an EC member of IIN, GC member of IEA, convener of the Epilepsy Surgery subsection in Indian Epilepsy Society. She coordinates a comprehensive epilepsy surgery care program at KIMS Hyderabad, and their group has performed more than 1,000 epilepsy surgeries. Over to Dr. Sita Jailashmi.
Yeah. Thank you, sir. Thank you for the kind introduction. My slides are seen, sir. Can I start?
Yes.
Yes.
Yeah. So, good evening to all the esteemed faculty. And I thank IIN and API for giving me this opportunity. So I was given 15 minutes and asked to talk about approach to status epilepticus, that is stage 1 and stage 2 of status epilepticus. All of us know that seizures and status epilepticus in the emergency room is a medical emergency, and the outcome is largely dependent on the etiology and also how early you treat status epilepticus. Early therapy is critical to reduce not only the morbidity, but it will prevent permanent neurological damage. And status epilepticus, the incidence has remained fairly same over the years, and possibly the etiology we are identifying more and more with the more causes like autoimmune status epilepticus coming into the picture. And it accounts for almost nearly 20% of the neurointensive care admissions. And most important is if you don't treat early, almost 12 to 40% will progress into refractory status epilepticus. If you look at the stages of status epilepticus, the stage 1 is the early phase or premonitory stage. It is usually occurs at home. And then stage 2, where the status gets established. That is, by 30 minutes, one should treat status epilepticus. But how many patients do come to the hospital within 30 minutes? That is the question. And if you don't treat early, there is a risk that it can progress into refractory status epilepticus. Today, we will be talking and discussing about the management of stage 1 and stage 2 in the emergency room. The stages, it is important to know because the mortality, if you see, by 30 minutes, the mortality is around 20%, and after that it increases to almost 40 to 60%, and this is determined by the underlying etiology also. So what is the definition of status epilepticus? Seizures lasting for more than 5 minutes or recurrent epileptic activity over a period of more than 5 minutes without regain of pre-existing level of consciousness. That is, if somebody has 2 seizures without regaining consciousness in between in 5 minutes, then also it should be treated as status epilepticus. The time has come down from 30 minutes to 10 minutes and now 5 minutes by the International League Against Epilepsy, identifying the importance of treating early so that there are no reversible changes. And whenever we treat status epilepticus, the most important is terminate the seizure at the earliest and as soon as possible try to identify the etiology and treat it, prevent the recurrence of status and seizures, and prevent the complications related to status epilepticus. So coming to the stage 1, that is 0 to 5 minutes, the immediate management is the moment when the patient had a seizure, at least ask the time and note it. Most important, secure the airway in a semi-prone position or a lateral position with nasopharyngeal airway, and oxygen should be started. Get an IV access and draw the blood for random blood sugar, complete blood picture, renal, liver functions, even the electrolytes, calcium, magnesium, and if possible, anti-seizure medications we can see, and toxicology, always we should keep a sample aside. And because we don't have time, we usually draw it, and after that talk to the family members if the patient is already on anti-seizure medications. If it is a drug withdrawal seizure, usually giving IV loading doses immediately will control the seizures. And if any video has been recorded by the patient family members, please look at it, because we have enough cases of non-epileptic events in the ER which are treated by the DMOs as seizures, and later we stop all the drugs and sometimes they get intubated. So what are the indicators for non-epileptic spells? Mainly the consciousness, usually the eyes are closed during the event. There will be side-to-side head and body movements, back arching, head rolling, pelvic thrusting. So if there is a video recording or if you are able to see, most of the time the residents record and tell us the seizures. So this is an example of a clear-cut seizures where the patient is already on ventilator, brought to the ER, and he is having seizures where even jerking of the both upper and lower limbs. And then if you look at this other seizure, this is a non-epileptic event. And he continues to have this where he is turned to one side. There is back arching of the back with legs flexed, eyes closed, and he continues to rock the bed. So we should be able to differentiate these immediately in the ER. And once you are sure that it is seizures, check if any treatment was given prior to coming to ER. If he takes alcohol, then give thiamine. Regular alcohol intake is there. And always do one random blood sugar. And if there is any glucose is low, start hypoglycemia. Start treating for hypoglycemia, especially if the patient is a diabetic. And also many times people will come to us with hyperglycemia. For the first time, the recordings are 400, 500 coming with seizures. And also, meantime, prepare the first line of drug, that is benzodiazepines for administration. If you see this patient who had a big scar on the abdomen for pancreatitis, developed diabetes, and comes to the ER with the 3 seizures, followed by continuously staring and having the jerking of the face continuously, who is in a initially convulsive status, and now he is having a focal status epilepticus, and his sugars were 820 at the time he came to the ER. Here before, anti-seizure medications do not help much in metabolic conditions. So you should control the underlying etiology. So here rapidly one should start the insulin infusion. And whenever we are treating the status epilepticus in the stage 1, the most important is speed really matters. The seizure control within first 1 to 2 hours of onset of the seizures is a determinant of positive outcome. So we should treat within 5 to 10 minutes by giving a first line drug, that is either midazolam or lorazepam. The efficacy of anti-seizure medications is highest when treatment is initiated within 30 minutes. So after this, we immediately give the loading doses of anti-seizure medications. And if there is any delay, the favorable outcome comes down, and early treatment of seizures is associated with better outcomes. So the most important is hit early and hit hard. So the first line drugs, we can use any of these, but nowadays we use mostly midazolam. That is because of the short half-life. So most important whenever we are giving this is we cannot give 1 milligram or 2 milligrams of midazolam. We should give a proper dose, which is 0.1 mg per kg. That is, in adult of 50 kgs, you should give minimum of 5 milligrams. So avoid underdosing of benzodiazepines. So use weight-based doses, whatever be the age. Do not worry about respiratory depression when you are giving this, because you are in the ER where you have all the armamentarium which is required to intubate the patient. More important is aborting the seizure rather than respiratory depression. If you are not, for example, intranasal midazolam has no role in the ER, and it can be given only by the family members when they are bringing the patient already if he is a known epileptic and having this. The other drug is lorazepam, which also is given around 4 milligrams stat. And there is no role for intramuscular midazolam unless there is difficult to access the intravenous line. The next important thing is intubation. If there is any concern or the patient is hypoxic, always appropriate to proceed for rapid sequence intubation. But however, most important is when the patient is seizing in a convulsive seizure, do not intubate. If the patient is a chronic alcoholic, always give 250 milligrams of thiamine followed by glucose. And then during the stage 1, monitor the vital signs, start cardiac monitoring, and if there is no response of the control of the seizures while we are preparing the loading doses, you can repeat the dose of midazolam again. And coming to the stage 2, that is 20 to 40 minutes after the onset of the status epilepticus, consider intubation if the patient is not getting controlled. And also meanwhile, send a requisition and make the preparations ready for an imaging and start giving the second line anti-seizure medications. We have now so many anti-seizure medications. Always it's a dilemma what to give. But nowadays, all of us know levetiracetam is the one which goes very rapidly because of the less side effects and easy to infuse. But however, all the drugs are equally effective. If you are giving phenytoin, we can give 20 milligrams per kg, which should be given slowly over a period of 20 minutes. Or if you are giving levetiracetam, give 60 milligrams per kg up to a maximum of even 4 grams. Most important is give the doses, full doses. We should not compromise in giving a small dose which is not effective, and there is a risk of continuous seizures and going from established status to refractory status epilepticus. And once we have given these anti-seizure medications, it takes 20 to 30 minutes for these drugs to start having the best effect. So we need to wait for really 30 minutes to know whether these drugs have really helped the patient or not. There is no point in pumping one drug after another. Phenytoin is still a good choice, especially in the district hospitals, but it should be contraindicated, especially when you suspect that it is related to some poisonings. If you look at the efficacy of the various anti-seizure medications in various clinical trials, we can see that levetiracetam is effective in 70%, valproate in 75%, phenobarbital in 73%, phenytoin in 50% of the cases as the first drug of choice in status epilepticus. And there is no significant difference between phenytoin and fosphenytoin because it's a prodrug. And this is often used when the benzodiazepines fail, and the pharmacological action, we know it is a sodium channel block, and hence the sodium channel blocker, and we should infuse this drug by slow administration at the rate of less than 50 milligrams per minute. And one should monitor the EKG because we have enough examples of patients having sudden cardiac suppression due to the drug. And if you look at, usually in young individuals, there are no side effects, but at extremes of age, there is an involvement of BP, which can be changed. And also the other side effects are, other than hypotension, one can have cardiac arrhythmias or infusion site reactions like phlebitis and soft tissue damage. Valproate is also a very good drug, excellent safety profile. And it is useful, especially when people have comorbidities, and there is no need for dosage adjustment when switching, and the dose is again 40 milligrams per kg body weight. And levetiracetam is the queen of all the anti-epileptic drugs when it comes to status as a first line. It is increasingly used in the critical care settings in the ER because of relative ease of use, positive outcomes, and low side effect profile. And nowadays we have ready to use preparations, and hence it can be just given within 5 minutes, unlike phenytoin, which has to be given over 15 to 20 minutes. Lacosamide is also another good drug, which is a slow sodium channel blocker. It is also easy to administer, but we need to give it slowly to avoid the risk of any cardiac events, though they are extremely rare. So this is the summary of the first and second line anti-seizure medications which can be given, and when you are using, what are the precautions to be taken. Phenobarbital usually we avoid, because after giving midazolam, if you give phenobarbital, it can cause respiratory depression. But however, if you are intubating, there is no problem. And phenytoin, be careful about arrhythmias. Sodium valproate can cause hyperammonemia, pancreatitis, thrombocytopenia, hepatotoxicity, though they are uncommon. Levetiracetam, safe and effective across all the age groups and hence widely used. Lacosamide sometimes can cause prolongation of the PR interval. And the next question is, do we give only one drug or more drugs? So normally phenytoin, valproate, levetiracetam are safe and equally effective following lorazepam in generalized convulsive status epilepticus in the study from NIMHANS. And AIMS also has done a study where they have said that giving 2 or more anti-seizure medications usually it prevents the need for intubation and ICU care. But if you look at the Western literature, most of the literature says if one drug fails, then there is no point in going on giving other drugs, and we should directly go to IV anesthetic drugs, saying that the patient has reached the stage 3 of status epilepticus. And meanwhile, identify and treat the etiology, whether it is a stroke or any infection, any trauma, and look at any metabolic abnormalities, especially common are hyponatremia, hyper or hypoglycemia, and correct these by the time you get the reports. And is there any role for EEG in stage 2? Usually if the patient is conscious, there is no need. But whenever there is a doubt to distinguish seizures from non-epileptic attacks, one should do an EEG. And also the patient is not waking up. It may be non-convulsive status epilepticus after the seizures have stopped. So we should do an EEG. And this is an example of patient having right-sided discharges in the EEG. And after some time, there is another seizure which is coming from the left side in an unconscious patient. Thus, it helps that we need to go to the stage 3 management in these patients. So just to summarize my last slide, in the stage 1, always it is ABC followed by thiamine, correction of metabolic abnormalities, especially the glucose hypoglycemia if it is present, and give either lorazepam or midazolam. And if after that, the anti-seizure medication can be either phenytoin or fosphenytoin or even valproic acid or phenobarbital or levetiracetam. And there is no class 1 head-to-head double-blind trials for these anti-seizure medications. And try only one anti-seizure medication. If he doesn't respond, go for the IV anesthetic drugs. All this is very important to reduce the mortality and morbidity of status epilepticus. In stage 2, once the patient reaches, the mortality is 20%. And if he goes to beyond this, it is almost 40%. And also morbidity is dependent on underlying etiology. And sometimes 1/3 of the patients with status epilepticus have significant cognitive impairment in the long run. So one has to act very early to prevent all these long-term consequences. So to conclude, always if there is a video of the seizures in the emergency department, look at it to make sure that you are treating the real convulsive seizures. And seizure control within immediate first 1 to 2 hours improves the outcome. After one first line and one second line anti-seizure medications, if they fail, go for intubation and start IV anesthetic drugs. And outcome mainly depends on the underlying etiology. Thank you.
Thank you, ma'am, for the wonderful presentation. I thank all the speakers for the use of presentation. We have 2 questions. Can we take the questions, sir?
Sir, we can't hear you.
Audible?
think sir is muted.
Sir, you are muted, sir. Mukundan, sir.
Dr. Mukundan, you are muted.
Am I audible, sir?
Yeah, now it is.
We have 3 questions, sir. I thank all the speakers for the wonderful presentation today. In symptomatic seizures,
Sir, you may try to increase the volume of your laptop or something. Voice is there, but it's very faint. So
Very faint, sir. We can't hear you.
sir, now?
yeah, better.
Yeah.
Better.
In symptomatic seizures, after how many days should we do EEG for the patient? First question by Dr. Praveen.
I think the question is that in symptomatic seizures, how many days after the seizures you do the EEG?
Yes, sir.
I think that is the question. I think Joy sir is probably will be able to answer that, isn't it? Is a topic.
Yeah, so you have to look at it in the perspective of what is the scenario in which the seizure has occurred. So if we know that there is a standard structural, metabolic, infectious, drug-related culprit, and there has been a single seizure, I'm not even sure I want to do an EEG to evaluate the event, because the clinical exam and the given clinical setting is going to tell us what we are going to do here. In scenarios where there is unequivocally a suspicion that a structural alteration has occurred in the brain, something like, say, herpes simplex encephalitis, you want both the MRI and the EEG as soon as possible, because it's an emergent setting. You want to know that the obtunded patient, what are the contributors to the obtundation. So I think we don't have a thumb rule. A lot depends on integrative analysis of the clinical situation, who the patient is, what's the scenario, what is the setting in which it has happened, and what's the underlying ailment. I mean, if one suspects that someone has had a transplant, for example, and is on tacrolimus or cyclosporin, and then has had a single event, you want the imaging to be the first parameter, because you're worried about either an opportunistic infection, depending on how long the patient's been transplanted. So I think it's very variable given the clinical setting. I wouldn't worry so much about the timing of the EEG. I don't know what the other august faculty thinks.
Thank you, sir. Next question is, why patients have symptoms have micturition?
Rathore, I think you should.
Yes.
So I think the question answer is that why patients of syncope have micturition. I think it is why patient of micturition have syncope. So that should be the question. Micturition syncope. So that's obvious. I think micturition sometimes, especially during the night, when you have a large volume of urine. So there may be, what I understand, there will be 2 factors. One is sudden, probably the vagal nerve stimulation because of the sudden emptying of the bladder and the bradycardia and the cardioinhibitory response. That will cause the micturition syncope. That's what I understand. And probably
sir, another question is, sir, question was actually why there is urinary incontinence during syncope.
Oh, that is the question. Okay. So urinary incontinence. Obviously, there is a same during the seizure, because after a syncope, it is hypoxia is prolonged. Actually, patient will have a inhibitory effect on the brain, and subsequently sometimes they can develop a convulsive seizure if there is a prolonged syncopal event, and during that event they are probably likely to have incontinence. So that is the reason. So it is not uncommon, and even both urinary and what I try to highlight that even both urinary and fecal incontinence can occur during the syncope, and that should not be taken as a criteria to diagnose seizure.
In fact, if I may come in here, one needs to understand that very peculiarly, because of the vagal effects of a syncopal event, it is not uncommon for a person with a vasovagal syncope to actually get an urge to defecate. So the urge to defecate is a part and parcel of the clinical semiology of a vasovagal syncope.
Thank you, sir.
After
So
the
the
event.
next question is, can epilepsy have stereotype hand movements like continuous clapping?
Again, I think I'm lost.
Yeah. So these normally in so-called complex partial seizures, now we call them as hypomotor seizures. The clapping movements are automatisms as a part of, usually this can occur in temporal lobe seizures or sometimes even in frontal lobe.
Kindly discuss about when to give seizure prophylaxis in stroke.
Sir, your audio is, I think if Dr. Bansal or somebody can, because sir, your voice is not at all audible. That's we are just, I think.
Yeah, sure, sir. I will take the questions.
Yeah.
The next question is, what is the drug of choice for focal seizures?
Okay, I think if Atmaram is there, it was his topic. Otherwise, any of us can answer that.
But I'm there.
Atmaram is very much here.
Okay.
So, the drug of choice, as discussed in the presentation, the for focal epilepsy, it is carbamazepine or octreotide, which is a time-tested drug. So that is you can use. The other drug, like nowadays, we do have lacosamide, we do have add-on like clobazam. So these are some of the drugs we can use. Otherwise, drugs like levetiracetam, sodium valproate, these are equally effective drugs. Sodium valproate we do avoid, except it is in a scenario that the seizures are not well controlled and you want to try some other drugs. As such, choice-wise, carbamazepine, oxcarbazepine, then add-ons like clobazam, levetiracetam. Levetiracetam can also be used as monotherapy in focal epilepsy.
Thank you, Dr. Atmaram.
Yes,
Next question to Dr. Atul Bhuj. Kindly discuss about when to give a seizure prophylaxis in stroke.
Okay, so I think it was Dr. Joy's question. I will take it. So to put in a single sentence, there is no role of prophylactic anti-epileptic drug in any condition, any acute symptomatic neurological condition. There has been no proven role of anti-epileptic drugs. So if patient has no seizure, there is no need to give anti-epileptic drug. With one exception, patient with moderate to severe head injury, where prophylactic anti-epileptic drug for a period of 1 to 2 weeks has shown to be some beneficial. Apart from that, in any condition, if there is no seizure, there is no need for anti-epileptic drugs.
The next question is about drug uses in pregnancy, that other than levetiracetam and lamotrigine, what is the allowable dose of valproate, carbamazepine, or phenytoin?
The drug levetiracetam, lamotrigine is no doubt very safe. Carbamazepine is equally safe. You can use it as per the dose required. Regarding valproate, as minimum as possible and as much avoid as much as possible. If the seizures are not controlled with other drugs, then if you want to give it 400 to 600 milligram per day, maybe a reasonably safer choice. Rest Rathod sir and Sita ma'am can comment on that.
Yeah. The clinical trials have clearly shown that valproate should be used below 600 milligrams, like Atmaram said. And carbamazepine also, minimum should be around 400 milligrams if it is really required to use, and maximum is around 600 in various clinical trials when used alone. But if it is used in combination with other drugs, again, the risk of malformations increases. So phenytoin usually we avoid using because fetal hydantoin syndrome is a problem. And nowadays we have so many other drugs. Now there is good evidence recently published in JAMA Neurology that lacosamide is can be used as when you can't use levetiracetam or lamotrigine. So like that, when we have these drugs available, usually we avoid these valproate, carbamazepine definitely because of neural tube defects, which is a major malformation.
Thank you, Ji. And next is again an open question to all the panelists, that any one of you uses ethosuximide in clinical practice, and how commonly it is being used, and what are the normal side effects, usual side effects?
Okay, who will go?
Yeah,
So,
yeah.
okay, so ethosuximide is the, if you take the evidence, it is the drug of first choice for purely for the absence seizures. It is not effective for any other type of seizures. So it is a drug of choice for childhood absence epilepsy who do not have GTCS or myoclonic jerks. Problem is that it was still till recently it was not available in India, but as now it is available and the experience we are gaining in it. Overall, side effects are similar to the other drugs, mild sedation or if higher dosage ataxia, but it is relatively safe drug as far as the cognitive problems are concerned. So if you ask me in practice, if it is childhood absence epilepsy, still I use initially valproate and lamotrigine, and if it doesn't work, then only I use ethosuximide, because we have been practicing like that. This was of the non-availability of ethosuximide, but now it is available, and if it's it is a good drug to be used in childhood absence epilepsy.
Thank you, Dr. Thor. We will take last two questions because we are running short of time. We are already 15 minutes late. One question is about continued anti-epileptic prophylaxis in post-traumatic seizures. What is the duration of prophylaxis after if we get acute symptomatic seizures after trauma?
Post-traumatic.
Post-traumatic.
Joy, sir, you want to...
So if there are acute traumatic seizures and acute concussive seizures, we normally can use an anti-seizure medication for 3 to 6 months. Nothing beyond that. There are very rare evolutions that can occur over a period of honeymoon, after a honeymoon period. It's not common at all where de novo epilepsy can develop after blunt injury. We call that post-traumatic mesial temporal lobe epilepsy. But that tends to take time. It doesn't occur in everyone. We don't know the true incidence, and one doesn't really worry about it. If there are an acute concussive seizures, and if there has been a demonstrable contusion in a regional brain anatomy, one can use an anti-seizure medication practically 3 to 6 months based on how frequently seizures have occurred. If it's just been 1 or 2 seizures, in 3 months' time, imaging shows that the contusion has resolved, patient's asymptomatic, EEG is normal, one could consider even withdrawing the medication. Not more than 6 months, I would think, if you are treating an acute symptomatic one.
Thank you, sir. Last question.
Sir, one patient with diuretic-induced hyponatremia.
Yeah.
Sodium level is 110. Had 3 episodes of brief seizures. EEG, MRI normal. Whether AED indicated here? If so, can we taper and when to taper? I think again to Joy, sir.
I didn't get the question.
Sir,
Hyponatremia.
Hyponatremia, the sodium level is 110. Had
Right.
3 episodes of brief seizures. EEG, MRI was normal. Whether AED is indicated here? If so, can we taper and when?
Yeah, so again, when you're treating hyponatremic seizures, the period is even shorter. It's an acute, really acute metabolic condition. So if one has understood what has led to the hyponatremia, and remedial measures have been instituted for resolving the hyponatremia. Once the hyponatremia is resolved, in 6 weeks' time, I would have no hesitation in taking it off. It's even shorter, because unless I think that the hyponatremia is going to be recurrent, that's a separate story altogether. So you would investigate the patient and figure out what's led to the hyponatremia, and then take a call. But I normally would take it off in 6 weeks' time.
Thank you, Dr. Mugandan.
Last question. Can we give herpes encephalitis in advance to prevent autoimmune encephalitis?
No, never. We should not do that.
Shall we close that?
Yeah, I know that there are many questions. It is a very common topic, but we have already exceeded 20 minutes. Can I request Dr. P.K. Maheshwari to thank all the speakers, panelists, and delegates and close the session?
Yeah, thank you, Dr. Bansal. It's a very good discussion and presentation by a lot of the eminent speakers and being attended by maximum attendance today was there from the physicians as well as the neurologists. And credit goes to all of you that you have presented a big topic in the 2.5 hour time. I think so. That's all credit goes to all of you. And probably because a lot of the messages are coming up that this should be second series of the epilepsy, because we have not touched like the psychiatric comorbidity, like different type of the things, because it's a thing that the physicians, they are all interested, because the first physician used to touch the epileptic first seizure. Then second, afterwards, he may be having a choice with the neurologist or whatever the circumstances. So here our aim is to coordinate in between API and the IAN. And so our mission is almost to the completion. And I think so we should finish because time is more than that. And I think thank you to all of you. Thank you, Dr. Gagandeep. Thank you, Dr. Girish Mathur. And thank you all our eminent speakers. And thank you all the delegates. Thank you, sir.
Thank you and good night.
Thank you.
Thank you, sir. Good
Thank
night.
you, Dr. Mathur.
Where are they? First wise one.